I'm Sean Fix with Emergency Medical Consultants. We're a national training center for a number of organizations providing continuing education for healthcare providers, fire, EMS, and industry. This video series that you're about to look at is designed to help you prepare for a certification course. Remember that it's not designed to make you leave your required manual or not do your required pre-course exams prior to entering the course. It's also a great review just for clinical practice and relevance. In this section, we'll take a look at the algorithms for managing cardiac events in children. While cardiac events are not as common as respiratory or circulatory problems, certainly we should be evaluating those in the whole scope of managing pediatric patients. So the stress of these guidelines basically are very similar to ACLS. Determine unresponsiveness, and if the patient is unresponsive, begin circulation, compressions, airway, and breathing. So remember that circulations are 30 compressions to 2 breaths if you're by yourself, but as most of you who are watching this video would be, if you're with the resuscitation team, it's 15 compressions to 2 breaths for children or infants, as we want to increase the amount of breaths per minute they get since they require a higher metabolic respiratory rate than adults do. We're going to do compressions at a rate of 100 to 120 times per minute, and an infant, the depth should be 1/3 the depth of the chest, or approximately 1.5 inches, and in a child it should be 1/3 the depth of the chest, or approximately 2 inches. As we open the airway with the sniffing position or a jaw thrust if the child has been traumatized and we think he might have a neck or back injury. We give 2 breaths, just enough to make the chest rise, so that may not be a full squeeze of the bag valve mask. And we still, just like the adult, get the defibrillator in the room and attach to the patient just in case he happens to have ventricular fibrillation, and at least to evaluate his rhythm. So those were the things we stress in pediatric resuscitation, very similar to adults. So when we look at the initial resuscitation sequence for any child or infant, we start with the same thing that we said on adults. We use what I call the circle of life. CAB, circulation, airway, and breathing. Assess, evaluate, and manage those. Begin appropriate CPR. Apply oxygen to the resuscitation device, bag valve mask, or positive pressure ventilation device, and continually provide CPR in 2-minute sequences before stopping for less than 10 seconds to reevaluate the patient and determine what the next step needs to be. Any other procedure is considered a secondary procedure, and while we still have a number of other procedures to complete, this is the most important part of resuscitation in children. Remember that waveform capnography, or end-tidal CO2, or what some people call PET CO2, is also used to evaluate effectiveness of compressions in children and effectiveness of intubation in children. The same as adults. So what happens is, after the patient is intubated, we would evaluate lung sounds and breath sounds, look for clinical presentation of an appropriate tube placement, and evaluate that also with waveform capnography or end-tidal CO2. A patient with his own pulse will have a CO2 of 35 to 45. A patient with no pulse and CPR will have a CO2 probably in the low teens. Ideally, what we're hoping for is a CO2 reading of 10 following intubation and compressions. So compressions are going to give us a lower CO2 reading than the patient's normal pulse will, and that's just the way it goes. So remember that CO2 is acid. The reading is 35 to 45 millimeters of mercury in the patient who has his own pulse. The patient who is in respiratory distress and going into respiratory failure will have a CO2 reading that starts to go higher as he has respiratory acidosis. A patient with low CO2 might mean that he's getting CPR, or that he's in a low cardiac output state for another reason, such as shock or trauma or blood loss. Patients who are perfusing normally and hyperventilating or being hyperventilated may also start to have a low CO2. But for pediatric resuscitation, the goal is recognize two things. Number one, use the device to assess an intubated patient to determine if the tube is in the trachea by getting a reading and a number. Number two, decide if your CPR compressions are effective enough by understanding that you should have a CO2 reading of at least 10 during CPR. So when we look at pediatric cardiac arrest, let's look at the initial assessment. So it should be, make sure you're in a safe area, check circulation, airway, and breathing, begin CPR, apply the monitor defibrillator to the patient to look at the rhythm, make sure you have oxygen going, begin CPR at 15:2 ratios once the team arrives, establish vascular access, maybe secure a better airway at some point in time, and once an advanced airway is in place during CPR, remember that we do continual compressions, one breath every 6 seconds. When we talk about having to calculate all this equipment and size and medications, remember that ideally we should be using some type of a pre-calculated system, whatever that means where you happen to work. We know that epinephrine works best in patients who are in asystole or PEA when it's given early. So having the ability to use your system, understanding it, to quickly draw up medications and administer them becomes critically important. We know that defibrillation works best the earlier we do it. So understanding your equipment, your procedure, and what type of device you're going to help you determine the dose of defibrillation is going to make you more effective and efficient at giving an earlier defibrillation. So if we look at the algorithm for asystole, just on the outside, take a look at the only drug that we give during resuscitation of a child in asystole is going to be epinephrine. We're going to measure that at 0.01 milligrams per kilogram, base that off of your dose calculator, whether it's a tape, whether it's a wheel, whether it's a chart that you've printed up for the patient. But if we really look at it, the most important part is the circle of life, doing good CPR with oxygenation and ventilation, giving epinephrine, and then every 3 to 5 minutes, giving epinephrine again. What I say is, since we're doing CPR in 2-minute cycles, that you should give epinephrine every other 2 minutes after you've stopped and evaluated the patient. That would be every 4 minutes, which conforms to the every 3 to 5 minute cycles. During each cardiac resuscitation, just like in adults, we should be looking for the things that start with H and the things that start with T that we might be able to reverse during this cardiac arrest if they're relevant to this particular patient. So evaluate for hypovolemia, give fluids. Evaluate for hypoxia, make sure you have an adequate airway and you're ventilating. Evaluate for metabolic acidosis by getting a blood gas, that's the H, hydrogen ions. Hypothermia, if the patient is significantly cold, warm them up. Hyperkalemia, if the patient has a potassium issue, evaluate that. Toxins, if there's an overdose that we can reverse it. Cardiac tamponade, tension pneumothorax, and coronary or pulmonary thrombosis. Address any of those at any time in any of the cardiac arrests. So as we move to the next algorithm, pulseless electrical activity, where we would have an EKG reading of something that should be viable, yet the patient has no pulse, we look at this algorithm and again realize this is the same algorithm as asystole. The patient should get epinephrine after he's got good CPR every 3 to 5 minutes, or again, I like it every 4 minutes, every 2-minute stop for 10 seconds or less, look at the rhythm, give the medication, have it pre-calculated, pre-drawn up and ready. And in the pulseless electrical activity, I think that the H's and T's are really important because when you have an EKG rhythm and no pulse, there's been some type of catastrophic event that's occurred to cause it, and sometimes that event can be found by looking at the H's and T's and managing those cases. So as we look at ventricular fibrillation, the ventricular fibrillation algorithm is very similar to the adult algorithm. That is, start CPR early on, defibrillate at an appropriate energy for that size patient. Again, the starting dose is 2 joules per kilogram, calculated by measuring him on some type of pre-set up device that you have. Defibrillate and then start epinephrine at that point. So we start our epinephrine, and then just like other ACLS algorithms, every 2 minutes we're going to rotate the vasopressor, which was epinephrine. The next 2 minutes stop, we will defibrillate again if it's still ventricular fibrillation, as well as use a antidysrhythmic, whether that be amiodarone, the more common use currently, or lidocaine, which is now approved to use as well. After each 2 minute cycle, you would rotate. The next 2 minutes you would stop, look at the rhythm, give epinephrine and defibrillate. 2 minutes later, you would stop, look at the rhythm, give either more amiodarone or more lidocaine and defibrillate. With each of those drugs, you can give 3 doses of an antiarrhythmic, a little bit different than the adult side. So the sequence is every 2 minutes, CPR, stop, check the rhythm, administer a med if needed, defibrillate if needed, and continue CPR. That's the VFib algorithm for pediatric patients. Once you've resuscitated the patient, post-resuscitative care in children looks like this. The goal is keep them stable, so ventilate or oxygenate them so their O2 level and CO2 levels stay normal. O2 at 94 to 99%, CO2 at 35 to 45. Maintain their distal perfusion and blood pressure with either fluids or inotropes. An antiarrhythmic infusion could be used at the physician's discretion if the child received an antiarrhythmic during cardiac arrest. Temperature control is important in children. Not letting them get febrile or hyperthermic is the most important portion of that. Monitor their blood glucose post-arrest as they can become hypoglycemic, and look at their other blood work, electrolytes, etc. Transfer or transport them to a pediatric critical care facility. In relation to hypothermia in children, the latest studies were a little bit vague on this. And what they found was there may be some effect that works in children, and the studies said either leave them normothermic for 5 days or make them hypothermic for several days and then normothermic for several days, or do neither. So the studies were a little bit vague on that for children. There are good studies in neonates and good studies in adults on hypothermia. Let's talk about perfusing dysrhythmias in children. So things that you have to ask: why would a child be significantly tachycardic? We have to look at a history, we have to look at the caregiver to get that information. So if the child is having a cardiac dysrhythmia, what I want to know is, number one, is there anything that would cause this? And I look at things like pain, anxiety, hypoxia, hypovolemia, even hypoglycemia are things that we should rule out before we say, hey, this is a cardiac problem. When we talk about bradycardia, we look at bradycardia in the cardiopulmonary failure section of this. But remember, here's what we say. If the child has a heart rate of less than 60 and they're showing signs of poor perfusion, that is, they are not awake, alert, they are decreased consciousness, they have poor perfusion, they have low blood pressure, we should oxygenate and ventilate them first before we think about any IV medications. If after 30 seconds to 1 minute of ventilation and oxygenation the child remains bradycardic, we should consider intubation and advanced airway, but we should also begin CPR chest compressions. If after 30 seconds to 1 minute of CPR and oxygenation and ventilation, the child remains bradycardic with a heart rate below 60 and poor signs of perfusion, we should administer epinephrine to that child. Epinephrine, again, dosed on your pre-calculated system, which would show you what 0.01 milligrams per kilogram would be. Occasionally, in the child who we think has some type of an overdose or some type of a pesticide ingestion or some type of a block, we might see atropine attempted, but not as readily as in adults. I look at personally 4 causes of bradycardia in children, and those are hypoxia, hypoglycemia, hypothermia, and herniation of the brainstem from head injury. When we look at the tachydysrhythmias, let's look at a wide complex tachycardia first, assuming that it is ventricular tachycardia. And the treatment in this, if we're diagnosing this as ventricular tachycardia, is that we should medicate them with either amiodarone or lidocaine as our initial medication. The amiodarone dose as calculated on your pre-calculated system would be 5 milligrams per kilogram, given slowly to the child over up to 20 minutes as long as he is stable. So in some cases, if the clinician is not sure if the dysrhythmia is a wide supraventricular tachycardia or a wide ventricular tachycardia, a trial dose of adenosine can be attempted in case this happens to be a wide supraventricular tachycardia. But for our purposes, let's just assume that a wide tachycardia for today is ventricular tachycardia. At any point in time, if the patient becomes unstable with ventricular tachycardia, and just like the adult, we say if the patient has CASH, serious chest pain, altered mentation, shortness of breath with pulmonary edema, or hypotension, that being hypoperfusion, delayed distal pulse or capillary refill, those patients should get joules. So the patient who has unstable, wide complex tachycardia should be treated with synchronized cardioversion. And that would be at generally 0.5 to 1 joule per kilogram, again using your pre-calculated system. You can increase it to 2 joules per kilogram if the first cardioversion doesn't work. The synchronized cardioversion is generally used if the patient is unstable or could be used if the patient fails to respond to the appropriate medication dose. As we look at supraventricular tachycardia, which is a more common event in children, the narrow complex tachycardia over 180 beats for children, over 220 beats for infants, is considered stable if the patient has good mentation and good perfusion. We could attempt a vagal maneuver, such as putting a bag of ice over the upper face and bridge of the nose, or if the child is older, having them blow into a syringe to try and blow the plunger out of the syringe while pinching their nose to force them to do a vagal maneuver. If vagal maneuvers don't work or are not indicated, adenosine at 0.1 milligram per kilogram, again on your pre-calculated dose chart, should be administered. You can double that dose if it doesn't work. If the patient remains in SVT, or at any time if the patient becomes unstable with SVT, that is signs of poor perfusion, the treatment is just like ventricular tachycardia. Synchronized cardioversion, 0.5 to 1 joule per kilogram, repeated at double that dose if needed, and after the third dose, going back to trying medication or trying medication for the first time if the patient is unstable. So I think what's important to remember in this lecture on the advanced life support for pediatric resuscitation is CPR and defibrillation are actually the most important part of this. Thank you.